Although this is a lecture, I'm very happy for people to ask me questions, to interrupt at any time and get a dialogue going. If people don't wish to do that, then I'll just carry on talking. Mukesh mentioned my surgical background. I did train at one point in orthopedics. And I don't know how orthopedics is viewed as a specialty worldwide, but in the UK the phrase is orthopedic surgery is simple surgery done by difficult people. But it's interesting bringing the world of surgery into these emergency settings, and in particular into public health settings, because surgeons and anaesthetists work in a particular environment. And one of the things we've tried to do in bringing surgeons and anaesthetists into disaster scenarios is to wrap them in a cocoon so as we can bring them out and they can operate and work and have around them a team of people who can negotiate and deal with all the much wider things. Because surgeons have a particular mindset different to physicians and very different to public health people. Now, I work, as Mukesh said, at the Humanitarian and Conflict Response Institute. This is a new venture between the Faculty of Medicine and the Faculty of Humanities. And what we're trying to do is to learn from each other and analyse past conflicts, past crises, in a shared way between the medical input that we can bring to it, but also we have historians, we have social scientists, we have economists who can help us view these issues in the round. We have a number of ongoing research projects at the moment. We're working still in Haiti, but now in a research capacity, reviewing the surgical inputs that were done, both in terms of their technical appropriateness, perhaps, or their technical achievement, set against the social impact that they've had. So we're doing a quantitative and a qualitative study on the surgical interventions that were done. And our two researchers are there at the moment. We also want to review past interventions. So, for example, the work that was done, in fact, I worked with Mukesh on both in Sarajevo and in Pristina in Kosovo. It's a good time now to review the impact of those interventions so much further on, which worked, which didn't. It was interesting going back to Pristina last year. The emergency department that we put in is still there, is still functioning. The intensive care unit is. So the physical things we put in have remained and are being used well and very well maintained. The changes to management structure within the hospital are exactly as we left them. No further, they didn't evolve any further. So they're the much more difficult things to change, as you would expect, I suppose. But the actual physical things we put in worked very well. We also have a research project in northern Uganda looking at the post-conflict situation there. We have two projects, one on gender-based violence, which we're working with the Institute for Peace and Reconstruction in Gulu in northern Uganda, and the other that we're looking at is access to healthcare, because they have a state hospital, they have a charity hospital, and they have a private hospital, all three of which say that access to healthcare for the very poor is free. So one hospital is far better than the other two, so why would anybody ever go to the other two? But they do, or they have to. So there's lots of social things going on there which we are exploring. And we also have a project reviewing Darfur, which I'm not personally involved in, but the Institute is. Our teaching programme, we have a Masters in Public Health with Emergency Humanitarian Assistance. And the Emergency Humanitarian Assistance module is one semester, which has 5 days of face-to-face teaching covering a whole range of very practical things, and also a number of online assignments covering the wider social and political aspects of emergency humanitarian assistance, and then the remainder of the MPH covers epidemiology and all the basic sciences required for public health. We run also an MA in Humanitarian and Conflict Studies, which again incorporates the module of emergency humanitarian assistance but explores much wider areas. So there are our two degree programs as it stands. I wear another hat. I'm a hospital dean at the medical school, and we are introducing a global health program for our medical students. We want our medical, and this is established and we are developing it, but we want our students to understand more about medicine in the wider world, and for some of them to be able to specialise, to major, if you like, in global health. And so each of their student selected components, each year they can do 1 month in a topic and a place that they choose. These have to date all been within the university, but we now have them placed in other countries, some in developing countries, some in developed countries, where the supervisors in those other universities, say in Malawi, we have one in Malawi, they will mark our students. We give them an honorary university contract with us, and they will teach and mark our students. And we will build up this cadre of students who will then do an intercalated degree, a master's in public health with emergency humanitarian assistance. And they will graduate in medicine with global health and emergency humanitarian assistance. So as we can build up a cadre of people who perhaps are better prepared than I was as a new graduate for work in this field. So that's the academic things that we are doing. To come to Haiti, my involvement with Haiti was very practical in that I run a team of doctors and nurses and paramedics who for many years now have responded in the emergency phase, often of earthquakes, but we have responded to conflicts. We have responded to a volcano once in Cape Verde. It's a small core team who have built up quite a lot of expertise in the management of crush injuries and the emergency surgical response. And it was in that capacity that we went to Haiti. Now, the premise that we work on is, as I say, this core surgical team supported, wrapped up by emergency medicine specialists, nurses and physicians. Now, this is a UK model. It's because we take surgeons and anaesthetists from the National Health Service. So they have their full-time job is not humanitarian work. Their full-time job is working in the National Health Service. But they have great surgical and anaesthetic expertise. And they also have built up experience of using this in emergencies. But for them to work most effectively, to hit the ground running and be able to get to work very quickly, we found it works best if we cocoon them completely. And that the emergency physicians and emergency nurses are quite good at selecting the patients for them, multitasking and supporting their work. So we get them in, we get them operating very, very quickly. Surgeons, we find, or certainly UK surgeons, get very anxious in a crisis if they are not operating, because they don't feel they've got anything to contribute, which is not true. But they feel that. So we get them in, we get them working, start feeding them patients, and then we just keep them operating. And the emergency physicians look after the patients before they come to the surgeons. We draw up an operating list, they do the surgery, and then we look after them post-operatively. Also, as emergency physicians, certainly in the UK training, I mean, I have a surgical qualification. I don't practice full-time as a surgeon now, but I can assist the plastic surgeons, the orthopedic surgeons, during the surgery when required. And so my having done surgery and internal medicine and in emergency medicine. So I can multitask, as many of us can. And then we have, surrounding that, we need administrative and logistical support to keep the whole team going. And on this instance, we teamed up with Merlin, Medical Emergency Relief International, and went out as a combined British response funded by DFID. And so Merlin provided all the administrative and logistical support, emergency medicine, screened all the patients, and then the core surgical team carried out the operations. We arrived, I think the earthquake was on the Wednesday, in the early hours of the Wednesday morning. We arrived at the weekend. Interesting that about deployment of surgical teams, there is a window for earthquake injuries. If you review the literature on injuries incurred, most major head injuries, thoracic injuries, abdominal injuries, pelvic injuries, if they are major, they will die. And that's regardless of the country. Because the amount of medical resources needed to treat large numbers of those injuries are immediately overwhelmed, no matter where you are. So for practical purposes, for international teams, you will not be dealing with any significant amount of head, chest, abdominal or pelvic injuries. You will be dealing with peripheral limb injuries. You will be with crush injuries to the arms and legs. There are some others. Sometimes you get compression injuries to the scalp, but by and large, you should be geared up for that. That's been our experience, and if you look at the literature, that's everybody's experience. So peripheral limb injuries, and you need orthopedic surgeons, plastic surgeons. Plastic surgeons, I would say, are probably more important than orthopedic surgeons. And that's because you're dealing with a lot of soft tissue injuries and skin cover and wound management, which is what plastic and reconstructive surgeons do. And also, if they come from a very developed country, their training will involve the management of bones as well. So plastic surgeons are a very good asset. We actually have an orthoplastic team, and we team people up with, they used to work in one orthopedic surgeon, one plastic surgeon, and they come as a box set, and they work together. Spinal injuries are a feature, and these are interesting spinal injuries. They do seem to be increasing. Now, whether that is because emergency resuscitation is getting better, and so that people survive other injuries than to be shown to have spinal cord injuries, or whether it's the nature of buildings that maybe crush people and cause crush fractures of the spine. But we did notice, particularly in China, to the earthquake there a couple of years ago, that it was people jumping out of high-rise buildings. When the building is about to come down, people jump out, and then they get severe compressive spinal cord injuries. And that was certainly recorded with the patients that we interviewed with who had spinal cord injury. That was, for China, in our experience, the commonest mechanism of injury for that. Now, spinal injury, the bone injury, is relatively straightforward to manage, but we have associated with spinal cord injury is a very difficult problem. It's so resource intensive, and very difficult decisions have to be made at a local and a high level for that. In China, for example, they just brought in a co-payment system for healthcare, I think 20 to 30%. And the patients with earthquake injuries, particularly spinal cord injuries, were given an amnesty for this. But that caused quite a lot of resentment amongst the other people with spinal cord injuries and with injuries not caused by the earthquake, because China has an awful lot of spinal cord injury from its industrial activity, its mining activity, and increasingly road traffic accidents. And so they had to rescind that sooner than they'd intended, because it was causing more wider problems than it was solving. But spinal cord injury is a real issue and will become an increasing issue in my view because of what we found. I was involved in a pilot trauma centre in the UK where we concentrated on the management of severe injuries, and you shift everything along. So people who would have died of certain things survive it, and some survive with a better outcome, but also you move it along, and people who would have died survive with a poorer outcome. So whilst you increase the you decrease the disability for the majority of people by improving trauma services, you do at the tail end have a group of survivors who survive with more significant disability, and it's just something you have to be aware of. And then there's the issue of amputations, and it's an area where I'm particularly interested. Professor Bertrand Taithe, who's my co-director at the Institute, is French, and his specialism is the history of medical humanitarianism in the 20th century. And he's particularly interested in amputations, and many of the issues that are coming out now about Haiti and about recent earthquakes and the role of amputation, he reminds us go back over 100 years. They go back to the Crimean War, they go back to the Franco-Prussian War, the same issues, again with outside medical help coming in and performing amputations, and then concern about it afterwards. So these issues are not new, but that doesn't stop us from having to look at them. So they're the three main things. From our point of view, if we are sending teams out, they're the issues that we know for sure we will be dealing with. Added to that is anesthesia. We do many, many cases under ketamine, which is a dissociative anesthetic. The patient remains conscious to some extent, but dissociated from what you're doing. And you can do a remarkable amount with that. But we will do cases under general anesthesia. Once you start getting into general anesthesia, then you need to have an oxygen supply. We can manage with a mild general anesthetic and do certain procedures without oxygen. We did that when we first arrived in Haiti. It requires a very skilled anaesthetist and a very experienced anaesthetist. But we won't do children, because children react very poorly to hypoxia. Their oxygen level goes down. Children become very ill very quickly. They have certain reflexes, some physiological reflexes that cause the heart to slow down and stop, and their breathing to stop at the moment oxygen level goes down. And so we won't do general anesthetic in children until we get oxygen. We did manage to get oxygen in Haiti after a couple of days. Just to compare and contrast with Haiti with China, we did work in Indonesia last year, but that, in our experience, was overcalled. The place was overrun with surgical staff. So we teamed up with Merlin for that and just sent a small surgical team to support them, but they tell me they didn't have much to do. But in China, we had a lot more to do. And the interesting contrast with Haiti is that Haiti had no system for stopping people coming in or controlling people coming in or filtering them, because it was already very, very vulnerable. It was vulnerable politically. It had a weak government. It was already being run to a large extent with the cooperation of the UN. All those UN workers were killed, including the head of the UN mission. And so controlling people coming in was very difficult. And a lot of complaints about chaos were in fact self-inflicted by the people going in my experience, compared to China, where they ask for help, and we are offered. The UK offers help, and then they ask for us to send our CVs. We had to send our CV to see if we would be of any use to them. China's not short of doctors, and they wanted to know what technical assistance we could offer. So we sent our CVs, and they saw we'd been to lots of other earthquakes. That's fine, you would be of some use to it. Now that's one extreme, and the other extreme at Haiti, where there is no filter at all, no check. I was talking to Mukesh before. One of the questions I like to ask people when they've been to these events and they're telling their stories is to say, were you registered to practice medicine in Haiti? And people used to get very angry when you ask them that. And they say, that's a ridiculous question. What do you mean was I registered to practice? Well, you're a medical practitioner, you have to be on a medical register. We have rules about these things, we have laws about this. So why you just turned up and started work? Was that legal? People get very, very agitated, but it's a good question because, well, the answer is, well, no, people were not on a formal register. We were not on a formal register. How would you, the process of doing that would be far too complicated and, you wouldn't wish to do it. So why would you need to be on a register? Well, for accountability. So the next question then is, okay, I fully accept you couldn't get on the medical register, say in Haiti or in China. So how did you make yourself accountable? And that's the next thing. So you make yourself accountable to the Ministry of Health, if you can. You make yourself accountable to WHO. You make yourself accountable to local and international bodies of repute. But not everybody does that. And I think it is a big issue about the professionalism of aid, is that the standards that you have at home, you must apply when you go abroad. Now that's difficult. Of course it is. It's very difficult work. But do you have to be looking to that to make yourself fully accountable? And one of the issues in Haiti, I fear, was the lack of accountability of not everyone, but of a significant minority. China, very well organised system. They have a major emergency programme, which we slotted into. And the sort of work that we do, which is quite technical, is predicated on there being a local framework in which we can support. And that's often the case, whether we've been in Iran or Pakistan or wherever, even in Armenia years and years ago. There's a framework and you slot in and you work alongside local colleagues and you do a variety of things. Haiti, there was no local framework, so very different. Nothing to slot into. Because whatever coordination, whatever framework there had been was very weak and was largely ineffective for quite a few days after the earthquake happened. So then you're faced with having to get your own facilities and set up your own hospital and your own network of referring patients and so on, which we did. We got patients referred to us from MSF. The Brazilian army had been there before the earthquake. They had a hospital facility. We acted as a referral centre for them. And we set up quite a specialist limb salvage surgical facility for limbs where people were tempted to amputate. Send them to us and we'll see what we can do. As in all these very poor countries, they have poor building standards. The mayor of Port-au-Prince had said the year before that 80% of the buildings in Port-au-Prince were about to fall down because they're being built very poorly and without any sort of regulation. So they were already about to fall down, and that contributed greatly. There is the old cliche that earthquakes have never killed anybody. It's only falling buildings that kill people, and so these are man-made disasters. The earthquake is a natural phenomenon. The disaster is man-made. So we arrived and we found a hotel, in fact, that had a swimming pool. The swimming pool was empty, I hasten to add, but there was running water and there was a lavatory by it. So that seemed a good place to camp. So we camped around this empty swimming pool, which was not too far from where we were to set up the hospital. Interestingly, the hotel was still functioning to some extent, but we couldn't get in because the BBC had taken all the rooms completely. And I remember one of the producers coming out in the morning and saying, "We feel a bit bad. about this, you know, that we're all here in the hotel and you are out here sleeping on the floor. I said, that's okay, swap. He said, oh, I don't feel that bad. But what was interesting, though, was that there was quite a large aftershock. And it was wonderful because we were just quite an experience, it being a big aftershock and being a tent outside where nothing can fall on you. So you think, oh, this is quite a life experience, this. And to see all the BBC people come running out of the hotel in their underwear, I thought it was quite made my day. Aftershocks are, of course, a big problem. When we were in China, there was a 6.4 aftershock, and we were 10 floors up. And that, I could see why people might jump out of high-rise buildings, because it just got to one point where we thought the building might come down, as the windows were cracking and things. And ooh, what's best? You know, go down with it. But then it all stopped. It was fine. So where to operate? There was a hospital in Delmas 33 that hadn't functioned very well before the earthquake. After the earthquake, the Cuban team had taken over the operating facilities there, and the grounds were really full of refugees. A lot of people congregate into hospitals, yes, some for treatment, but also to be in a safe area where they might get food and water and so on. So opposite was an abandoned tennis court. And so we set up there. We were directed there by the mayor of Delmas as to where we would work. That's Lewis, our local doctor, and it's very important in these events to harness local expertise and work alongside people. And Lewis was great for us. He helped us get all the facilities that we needed. He translated into Creole when we needed it. He was a great help. And gradually we expanded into quite a large tented facility. I'll just run through some of these. Although we're primarily a specialist surgical facility, you will get non-surgical cases coming. You are a medical facility, people will arrive. And so we are prepared for that. We also wanted to make a point of working with other organisations. So we formed a cooperative between what was essentially a Merlin team providing the surgery. There was Goal, the Irish NGO. They provided all the primary care. And there was a local NGO that had been working there for about 10 years, I think called International Faith Mission, a Christian group, an American Christian group that had been established there for some time. They'd been running a small clinic, really, not a hospital, for 10 years, and that had been destroyed in the earthquake. And so they came to work with us, and between us, we could run really quite a large facility. And I was very pleased that, you know, you often see so much competition between NGOs, and this worked very, very well together, each playing to their strengths. And I think that's important, not trying to do the other's job. You do what you are good at. Yeah, so we set up a waiting room outside. We had an emergency room where the Irish physicians from Goal just ran it like a GP surgery cum emergency department, and they probably saw about 300 cases a day that went through that. They just kept coming through, dawn till dusk. And so in terms of numbers of patients seen, they saw the highest number. At a dressing clinic, these were Mennonites. It is a American, they're rather like the Amish, they told me, who were the International Faith Mission. And you see with the headdress on, they go there. And so these were all volunteers from the States, and so they ran the dressing clinic, which they ran very, very well. So they cleaned wounds ready for surgery for us, and they did a dressing clinic afterwards to follow up the patients that we'd operated on. and before we had a generator, but before we could get fuel for it, we had to be quite ingenious about how we fired up the autoclave, which we did with a little gas stove, in order to sterilise our instruments. We got oxygen. We got oxygen from the Brazilian army, and we got that on the second day, and they just filled cylinders for us. And once we got that, we could operate on children, and we could really lift our game with that. Supplies are very important. We carry basic supplies to start off immediately. We had others following on. Then, of course, WHO kicked in, and we could get then a continuous supply of material. So we were not short of kit. That was our initial operating theatre, which was in a tent. And obviously, pure sterility is very difficult in those circumstances, so therefore we try even harder about the rules of engagement for the operating theatre. We had a Scottish theatre sister, as we call them in the UK, who frightened everybody, and she was very strict about access to theatre and cleaning it. Very, very strict, and it worked because we didn't have any problems with that. So much so, as we went on, we could open up a second operating theatre in another tent to deal with the load. The goal team had an eye surgeon, and so there were orbital injuries, so facial injuries, and with quite severe eye injuries. Most of the operations were enucleation, to actually take the eye out, unfortunately. But it's very important that with a damaged eye, that there is a condition where, if that eye is damaged, you can lose the sight in the other eye. It's an autonomic reaction, and so at times you have to take that eye out, paradoxically, to save the uninjured eye. And so he did a lot of enucleations. And then orthoplastic surgery. That white bar going up is a C-arm. We had portable X-ray. In my time doing this, the technology has moved on enormously. The thought of taking an X-ray machine with us when I first started doing this would have seemed ridiculous. But the technology is such now that you can take all this equipment with you. And the moment you've got internet access, whether that be via satellite or whatever, the moment you've got internet access, you can consult worldwide. So you're not isolated. You can tap into surgical expertise with ease. What we're looking at now is we're going to have our X-rays reported on back in Manchester instantaneously. So we'll be in a tent somewhere, but our radiologist back home will give us an immediate report on the X-rays. I would encourage people to embrace the technology that we have now. Even going back to Kosovo, and one of the cases we had there was a multiple gunshot wounds to the abdomen, where he'd developed a very severe infection, had been very poorly treated, and they had all these abscesses, and the chap was going to die. We had a group of surgeons there who had basic surgical training but could not deal with such a complex intestinal problem. So we emailed photographs via satellite to a surgeon in Manchester who ran a referral centre for complex septic problems in the abdomen. And he guided them through the operation. Absolutely fine, and the patient made a full recovery. Now that's going back 10 years, using emailing digital photographs. Now you can go on Skype. So I think, we really want to embrace this technology. See, what was that? Google. Yes, you can Google, yeah. Sepsis of the abdomen, help. And you'll be surprised. I mean, I love this sort of, the use of the internet. There's an organisation in India that provides online medical advice for rural India. And it gets put through to me, so you're in the middle of a meeting in Manchester and you bing, I think it's fantastic. So I think there was the idea of telemedicine when it first came in. I always sensed people thought it was overkill, that it was far too technical, it would never work out in the field. And probably at the beginning that was right, but not now. The technology is such that I really think we should embrace it, and particularly for consultations. So as you can actually, and it's a good educational tool. There was a paper written about Tele Dermatology in New England in the States, which is very telling. Of the islands off the East Coast, they were sending patients in to the mainland for dermatological consultations. And so and lots of the time, the dermatologists thought it wasn't appropriate or whatever. So what they did was they set up a telemedicine link, and the dermatologist sat in their office, and the patient came in with their own doctor on the island. They looked at things, and the dermatologist gave advice and said, and that worked very well for about 3 months. And then the cases stopped coming in. And when they looked into it, it was because the local doctor knew what to do now. He didn't need to do the consultation anymore because he saw what the dermatologist was doing. He knew how to make the decisions. Now, I think we can use that to great effect. You can have people alongside you, watch the thing, learn the decision-making process. Just moving to education, we're doing that with our contacts, with our global health program we're doing with hospitals all around the world. This lecture's being videoed. We're doing the same thing. Why can't the link we have with Uganda and with Malawi, we're giving a lecture, obstetric emergencies, ping it to wherever we are associated with. I think we have to really embrace it. Probably rural India, that is it, asking for advice. We actually ran 2 tables at one time, not best practice, but in order to get through to the backlog of cases that we saw. And right, it's drilling a leg, putting. Orthopedic surgery, it's a lot like carpentry. That is an electric drill, and you're drilling in a piece of metal to fix a fracture. No. He's actually an anaesthetist. Because he's an anaesthetist, and he's multitasking, so he's checking the drugs and at the same time helping the orthopedic surgeon by. You can see he was a frustrated surgeon. He sat as an anaesthetist all these years, gassing for these people and thinking, I could do that. And so he's got it, and he was amazing. He's got, look at this! Whoa! Oh, terrible. I'm sorry, he was very professional about it. There's the X-ray. And these are the sort of crush wounds that you see. These have been treated by the dressing clinic. The wound is now quite fresh. Probably looks horrible to you, but that's nice and fresh and ready for a graft. Similarly, you can see compression injuries. They've been under masonry. The overlying skin gets necrotic. You take that off, clean it up. That will take a graft. There's a young child. Sorry, you may not like some of these pictures, but you have to, you get deep internal crush injuries, so you have to open up the tissues deep inside to clean out all the infection. This is limb salvage surgery. Many of these, the limb would have been taken off, but if you actually open them up, clean everything out inside, and look at them every day, clean everything up, you'll be surprised at the results that you might get.
Is it recovered or does it lead to amputation?
Sorry?
Is it recovered or
Absolutely recovered.
without amputation?
Without amputation. Okay? We'll come on to our statistics for amputation in a minute. Also, I want you to show, this is the notorious external fixator. External fixators are a mixed blessing in emergency surgery in these crises. I say that because they are a great step forwards. You can fix fractures very well. They are relatively straightforward to apply. You can see an anaesthetist was putting the pins in for one. They are relatively straightforward. And what might appear quite high-tech can be done. This is done out in Haiti. We're doing them all the time. So they work very well. The downside is you have to make arrangements for them to be taken off. That's a big problem. That we, on returning to Pakistan 4 or 5 months after the earthquake, there are people going around up in the hills with now festering external fixators on. Foreign teams would come in and put them on, but no arrangements for them to be taken off. And so you must do that. by all means, put them on, but you have to make arrangements for them to be taken off, if not by you, by somebody else, which then comes back to accountability and follow-on, because the big area to be addressed about the emergency input is the follow-up. One of the weaknesses in Haiti has been the lack of organised follow-up by the people who did the immediate surgery. And you wouldn't do that in your own practice. You don't go in the UK, you don't just, all you do is that operation. You don't see the patient beforehand, you don't see them afterwards, you don't make arrangements for follow-up. It's a whole package. So you have to see it in that way. Now, it might be that you can't do it personally, but you have to make arrangements for it. So, can be a very good thing, but not always. More of the same. Lots of skin grafts. If you look at the skin graft on here with the little blisters coming through, you can use a mesher. I don't know, probably not very familiar with skin grafting and plastic surgery, but you need only take a small amount of skin, then we put it through a mesher that makes it like a string vest, and it stretches out, and then you can cover a much larger area with it. The advantages of that are that you don't have to have as big a donor site, and also the little holes in it allow blood and fluid to seep out, and if that didn't happen, then the graft could be lifted off by the oozing that goes on underneath, and then it won't take. So if you do that. And by and large, we stapled them. There are mixed views amongst plastic surgeons about the use of staples. They are very quick to do. It's just like an ordinary office stapler, and you just staple the graft on, click, 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 and it's very, very quick. The other problem is getting them out, because you have to have the equivalent of a staple remover, and you've got to make sure that the people who are doing the follow-up, A, have a staple remover, and B, know how to use it, and will take it out. Okay. Then I shall flick through to the issues. Okay. I will round up by discussing some issues I'd like us to consider. Malaria, typhoid, cholera, malnutrition. People are, these are issues that people are worried about following the earthquake in Haiti. But these were issues before the earthquake in Haiti. And we have to consider about vulnerable countries. I'm very keen that the emergency humanitarian assistance moves into development. There can appear to be a separation between the two, as though they were different functions, and they're all part of the same thing. Emergency medicine and public health are not mutually exclusive. You can be setting up all your public health, your primary care facilities from the outset, of course, but alongside you, particularly in the early weeks, can be an emergency response to deal with those cases that can be dealt with. And I would encourage a greater cooperation and merging of these various functions, rather than them being in different silos. Because the moment you go into silos, you start competing. One kills many thousands of people in Armenia, and there's only a few hundred died in California. And of those few hundred that died, it was largely that segment of motorway that collapsed, that was not built to regulations. It was built illegally. So it's the same natural phenomenon, but factors of economics, and economics are governed by politics, determined the different outcome. If you look in China, all those schools that fell down and killed all those children, I walked past those, and the buildings by the side were cracked and damaged, but were fine. And then they were pancaked. And that's poor building quality. So that's what I mean by that. The reason why I get a bit anxious about using a natural disaster, it implies there's nothing you can do to prevent it. And that's not correct. You can mitigate by appropriate investment in preparedness and architecture and so on. In the UK, for example, our specialty used to be called accident and emergency medicine. but we dropped the accident because that implied that accidents were somehow just happened and they couldn't be prevented. And of course, many of them can be, and their effects can be mitigated. You will know about the different health statistics between the UK, for example, and Haiti. And just to give you an idea of the degree of their vulnerability before the earthquake, which can only impact later. So, some issues. Dealing with the dead. This has been an issue I've faced with all the time. There have been some improvements in understanding that dead bodies, by and large, pose no risk to health. There are certain exceptions, obviously cholera, Ebola virus, the viral hemorrhagic fevers, but by and large, dead bodies pose no actual risk to health. But it's always an issue when you arrive in these places, because people are more concerned about dealing with the dead bodies than they are about dealing with the living and with the public health issues. And it is still an issue, and I believe we've not done enough yet to deal with the media on this. It needs some great television program or something to actually address it head on, why the people in the media still fuel these concerns. I mean, in Armenia it was the same when I was there, and it's every earthquake since. You can understand with scenes like these why people are terribly distressed and terribly frightened. I understand that, and you have to control and manage those fears. But it is not, we know as physicians that it is not a priority to actually deal with that from a disease prevention point of view. And it's not just me, I mean, much is written on this subject. But we're not having the impact that I think we should. Amputations. Now, it's thought to be over 4,000 amputations were done. We don't know what the figure is for Haiti. We don't know because there was very poor record keeping and documentation. We're trying in our study that we're doing to document it, but we don't know. And also the issue of guillotine amputations. You'll find that people in the very early stages just do a guillotine amputation. That is no skin cover, just straight through. Now, there are surgical indications for that, but that's only if it has a primary procedure. It has to be followed up by the same surgeon to get skin closure to create a useful stump. Unfortunately, all the guillotine amputations we saw, there was no follow-up arranged. This is from China. They did guillotine amputations there, but this patient's in hospital to have their follow-up procedure to get a closure. We didn't see that in Haiti, and we saw it in very young people. And you can see there was no, that's just raw flesh, there was no attempt to make any skin cover. And that was a 3-month-old baby. It was interesting, that child. It's another issue about NGOs taking children to other countries. We saw this patient on behalf of MSF. She was in the MSF camp, MSF hospital, and our plastic surgeons tied it up. She had a burn from before the earthquake to her head that needed sorting, and the stump needed sorting. So we did that, and then the baby went back to the MSF camp. And ultimately, some charity took her to the UK as an orphan, and they found out, in fact, that she wasn't an orphan. Her mother, she was in the hospital. The mother thought she'd been killed in the hospital because she went to the hospital after the earthquake, and she wasn't there. She'd been taken. So that's the wider issue about particularly children and repatriation. But from the UK team point of view, we did 623 major operations in 3 months. That's we also did probably twice as much, again, minor procedures that were just done under sedation, just reducing fractures and putting plasters on. And then we saw all the outpatients. But only 6 amputations out of those in the whole time. So you can keep the number down. What the figure for amputations will be for Haiti, I don't know. The statistics are difficult to interpret for all these things because if you compare it to the total number of recorded injuries, amputations are always very, very low. But of course, most of the injured people don't get into the big hospitals where the amputation might be done. So if you start comparing them with actual patients treated in the hospital, that's probably of more use. And the published figures show, for China, 2 papers, 5.5 for one, 6% for the other, so moderately high. BAM earthquake, it depends that people, which hospital published the results, because hospitals very near the front line, as it were, did more amputations than those much further back. So there was a range of them. Pakistan, the published figures are very low, but our experience was that that does not reflect what actually happened. But many were done in small hospitals up in the mountains where there were where records couldn't be collated. Sorry?
The figure of 624 operations, is that also lives saved?
Yeah, we had 1 death.
But I mean, if those people hadn't been reached, they would likely...
Oh, they would have died. They had serious septic problems.
I'm just trying to get a sense of how much of this is, dealing with normal injuries.
Oh, I see.
And how much of it is actual critical life-saving. Okay.
We've not finished the analysis. What we will do is use the injury severity score when we get all the data in. There's an abbreviated injury scale. I don't know whether you are familiar with it, but it's an international way of recording the severity of injury. And you can build that up into what's called an injury severity score. Then you can compare. Because words like life-saving or severe are very subjective. And so there has been now for 20 years a scoring system which allows you, because what combination of injury is severe, for example, is a chest injury and a leg fracture more serious than a head injury and a wrist fracture? It's very difficult to just do it just with those descriptions. But if you use the abbreviated injury scale, you can make a much more valid comparison between combinations of injuries.
The reason I'm asking is in connection with your point about sustainability.
Yes.
How much of this is something you can do as an intervention and you leave, it's okay.
Yes.
You've saved lives. You don't, in that sense, need to worry too much about the future, and how much of this is you're creating a standard that cannot be maintained.
These were all earthquake injuries, and people who would most probably have died without that degree of surgical intervention. Whether or not we've seriously upset the health economy there, we will review. But that, I take your point, and it's something I'm very conscious of, and what I keep reminding myself is that my intervention is not inherently benign. I hope to mitigate the negative effects of it, but you're quite right. But we worked with local surgeons, they worked with us. The actual techniques we applied in these circumstances are not very sophisticated on an international surgical level. Skin grafting like that, whilst it might look very graphic, is very straightforward, simple surgery. It's only cleaning out wounds. What we did bring to it, and what we try to do repeatedly, is to encourage people that you have some time to play with in terms of deciding whether or not to amputate. People are very worried that they will get overwhelming infection, and so therefore I must amputate now. Now that is true for war injuries, but these are not war injuries. They are not inherently infected. If you get a bullet going through you, then that takes contaminated clothing, contaminated skin deep inside you, and from the outset it is contaminated. These are not contaminated. They are crush injuries, and it leaves you some time. That's why I say that for medical or surgical teams to go out to these earthquakes, you don't have to go immediately. We aim to mobilize at about 48 hours, because as an international team, you will be treating a self-selecting group of survivors, because all the major injuries, if they didn't get immediate surgery, they will be dead. And so you do have some time to play with, but once you get there, you then have to move quickly. But if you manage the tissues well, take away, debridement, take away all the damaged tissue, irrigate the wounds well, manage them so as the swelling tissues don't cut off the circulation. They're just basic surgical techniques. Can I just make a point about medical records and accountability? This was an American observation, but there were no physical records accompanying patients to indicate their diagnosis, operations or care plan. We found exactly the same. That when we arrived at the weekend, the surgery that had been done in the immediate aftermath, there was no record of who the surgeon was, if they were a surgeon, who the surgeon was, why they'd done this. Had they got consent of the patient? There was absolutely no. The patient, we're doing a qualitative study. Many of the patients that we're interviewing now say they were never asked for consent. Their surgery was just carried out. Medical records, the way we do it, is we write them in longhand and we photograph them. Digital camera, and then they go on a laptop. And so we keep the paper record with the patient. They may get lost, but we know that they're always on there. There's an electronic copy there. And if worst comes to the worst, then we take them, we have them on a stick and we can. So that it's very important that there is this record of what was done, by whom, and that's kept.